That was perfect, Umberto, because you showed us a need that we still have. And so what I'd like to do now is bring up my slide deck. And I'm going to give you new data on protecting medically ill patients from venous thromboembolism and from stroke. You heard from Dr. Compia about the success using low molecular weight heparin in hospital for VTE prevention. And he really zeroed in on the critical unmet need during the first month after hospital discharge. 3 prior megatrials, one with Rivaroxaban and Magellan, Apixaban with Adopt, and extended Enoxaparin with Exclaim, failed to show any net clinical benefit in DVT and pulmonary embolism prevention after hospital discharge. And now we have approved last year the 5th DOAC, Betrixaban. It's approved for initiation during the hospitalization and for a total dose of 35 to 42 days to prevent PE and DVT. Well, when I started to dig into the problem of pulmonary embolism and DVT after hospital discharge, I soon learned that this is a problem, but I didn't think it was actually happening at Brigham and Women's Hospital. And that's because our hospital has about an 80 or 90-year interest in thrombosis and prevention of thrombosis. And we have a lot of experts throughout the hospital in different disciplines who are really zeroed in on VTE prevention. But then I started to dig for additional data to see what's the real intel at Brigham and Women's Hospital, thinking that we would have really great results. And that we wouldn't, because if you think about it, how many patients do you really know who've been rehospitalized within a month after discharge with PE or DVT? And I'm sorry to say that the Brigham is the blue bar here. Our rates of a new DVT or new PE requiring readmission to the hospital, and this is on medical service patients, are higher than those of the entire Commonwealth of Massachusetts, shown in black, and higher than those of the entire United States, shown in green. Now, I don't really think that we're more cavalier about VTE prophylaxis. I think we have a sicker population than other places. But the point is, all our hospitals are, no matter how conscientious we are, all our hospitals have this problem. Despite in-hospital VTE prophylaxis, there are more than 400,000 events annually in the United States in medically ill patients after hospital discharge, and half of these events occur during the first 6 weeks after hospital discharge. And prior to Betrixaban, there were no FDA-approved agents for extended duration prophylaxis. Well, we live by the motto, an ounce of prevention is worth a pound of cure. Betrixaban is not just any other DOAC. It's not really a me-too agent. It is different from the other factor Xa inhibitors. First of all, it has a really long half-life, about 24 hours. That means you can give once daily dosing reliably. And it has a low peak to trough ratio. And for those of you who are not pharmacists, that means you give the drug and pretty much you get a steady state for the next 24 hours. Depending how you define renal clearance, its renal clearance is anywhere from 7% to a maximum of 17%. Very little renal clearance. This is good because almost all of our medically ill patients who are hospitalized have chronic kidney disease. So you want a DOAC that is cleared through the liver, not through the kidneys. And there is an antidote that's under development. We'll know on May 4, which is just around the corner, whether the FDA approves Andexanet, which is a universal antidote for all the factor Xa inhibitors when major bleeding occurs. So here you have a really comparison chart looking at Betrixaban in the left-hand column compared to the other four DOACs. Longer half-life and less renal excretion than the other four DOACs, and there are no CYP3A4 interactions. This is the pivotal New England Journal of Medicine trial, the APEX trial, that led to the FDA's approval of Betrixaban. In most cases, the FDA requires 2 large trials before it will approve a new agent. But if they feel the evidence is of sufficient power, they will approve a new med on the basis of 1 trial. And that's what they did with Betrixaban. The APEX trial enrolled more than 7,500 patients who were medically ill, and the main medical illnesses in this trial were heart failure, respiratory failure, infection, and stroke. One important point about the APEX trial is that the patients were, in general, at higher risk for DVT and pulmonary embolism than those 3 failed megatrials that didn't show any advantage of extended duration prophylaxis. And APEX was a double-blind, double-dummy, randomized controlled trial. That's the strictest type of trial you can have. And it was 35 to 42 days of oral Betrixaban versus 6 to 10 days of injected Enoxaparin, 40 milligrams. And the primary endpoint in APEX was to look for reduction of venous thromboembolism and reduction of VTE-related death. Here is the flow diagram. I'll just point out that at visit 3, around day 35, patients in the APEX trial were summoned back to the hospital for a venous ultrasound exam of the legs. Of course, if they developed symptoms of DVT or symptoms of pulmonary embolism before the 35 days, they were worked up with CT scans and venous ultrasounds beforehand. And then I want to also point out that after day 35, the patients were followed for another month to see whether the benefits of the extended duration prophylaxis continued after all medication related to VTE prophylaxis was stopped. So what are some of the key inclusion criteria? Patients could get into the APEX trial if they were 75 years of age or older, or if they were 60 and older with an elevated D-dimer, or if they were 40 years of age and older and they had either a prior episode of VTE or the presence of cancer. There was one universal inclusion criterion that during the first 24 hours of hospitalization, the patients couldn't really be much more mobile than going from their bed to the bathroom and back to bed again. But I think that's true nowadays for most patients who manage to make it into the hospital rather than the observation unit in any hospital in the USA. I'm a cardiologist, so this trial enrolled 45% of its patients with heart failure. Heart failure is becoming ubiquitous. I think part of the reason is we're doing such a great job saving people who suffer from acute myocardial infarction with our cath labs and our statins and our aspirin and our beta blockers and our ACE inhibitors and our antiplatelet therapy that our MI death rates really plummeted. And over the next few years, what happens gradually is patients will develop heart failure. And that's, if you look at many of our coronary care units, these patients in the CCU, mostly coronary artery disease is not the #1 problem. It's heart failure is the #1 problem. Also, the APEX trial had a lot of patients with acute infection, often pneumonia. And they had patients with respiratory failure due to pneumonia and or chronic obstructive pulmonary disease. 10% of the patients were admitted to the APEX trial because they had a stroke and they needed prophylaxis against pulmonary embolism and DVT while they were hospitalized for management of a stroke. Okay, well, just to jump right into it, the primary efficacy point, which included a lot of asymptomatic proximal leg deep vein thrombosis, this was reduced by 24% in the Betrixaban group compared to the group of patients who were receiving Enoxaparin. Now, I know there's a lot of skepticism about whether an asymptomatic DVT really means much of anything clinically. I hear this over and over again. You know, if you're not having leg pain, it's probably not going to be as serious an event as if you have symptoms of DVT. That's a common thread that a lot of healthcare providers have been taught throughout their careers. Well, here you have data from a previous trial with dalteparin. This is in the PREVENT trial. Dalteparin has been FDA approved for in-hospital VTE prophylaxis. And what you find here in the patients who had asymptomatic proximal leg DVT, 40% of them were dead by 90 days, compared to 2% death rate of patients with asymptomatic DVT 90 days later. So there was a 7-fold increase in the death rate if you had an asymptomatic DVT versus no DVT. Well, that was in the PREVENT trial. I can tell you we've just submitted a manuscript on a sub-study of the APEX trial. We're finding exactly the same results now in 2018 in the APEX trial, that the asymptomatic proximal leg DVT has a very close association with death that we found back when this PREVENT trial paper was published in 2005. Okay, well, if you're still not convinced, let's look at the results in the APEX trial with symptomatic DVT. Well, with symptomatic DVT, there was a 46% reduction in events with Betrixaban compared to Enoxaparin. Nowadays, if you want to present a drug for approval to the Food and Drug Administration, you have to do a certain number of obligatory analyses. The FDA is really interested in knowing how many of the outcomes are either fatal or irreversible. And what we find in the APEX trial is there was a 29% reduction in fatal or irreversible outcomes with Betrixaban compared to Enoxaparin. And that's right in the middle of the slide. If you go to the far right-hand side of the slide, you see now there's been no drug given for 30 days. The results persist. This advantage of a reduction in fatal or irreversible events with Betrixaban compared to Enoxaparin. This persistence, after the trial's over, is what's called the legacy effect. We think there's a legacy effect using Betrixaban because when we do quantitative venous ultrasonography and measure the thrombus burden in 3 dimensions for high, moderate, and low thrombus burden, Betrixaban has a much lower thrombus burden than Enoxaparin. And we think that Betrixaban does a better job cleaning out clot from the vein. And once the clot is cleaned out from the vein, of course you stop the medication, you're going to continue to have those beneficial results, the legacy effect. Now, another thing that's very important, whenever you're looking at a study of anticoagulation, there are 2 sides of the coin. One side of the coin is the possible reduction in thrombosis by giving an anticoagulant. But the other side of the coin, you could say the ugly side of the coin, is the major bleeding complication rate. Usually, with most drugs, most anticoagulants, the more you reduce the thrombosis, the more you increase the major bleeding. However, that was not the case with Betrixaban. With Betrixaban, there was no significant difference in the major bleeding complication rate between Betrixaban given for 35 to 42 days compared to Enoxaparin given for up to 10 days. This is even more remarkable because in general, the longer duration you have of exposure to an anticoagulant, the more likely you are to have major bleeding complications. But that was not the case with Betrixaban in the APEX trial. Well, what do we as healthcare providers care about the most in terms of bleeding? We want to prevent fatal bleeding, and there was 1 fatality in each of the 2 groups in the APEX trial. But the worst type of bleeding for us is the intracranial hemorrhage. There were 7 intracranial hemorrhage events with low dose, 40 milligrams daily of Enoxaparin versus 2 intracranial hemorrhage events with Betrixaban. Now, when there were blood clot events, PE and DVT, Did APEX find the same pattern that Dr. Compier referred to in his talk? Did most of the events occur after the first 10 days of hospitalization? Yes. In the ADOPT trial with Betrixaban, in the Magellan trial with Rivaroxaban, and in the APEX trial, when there were DVT and PE events, they usually occurred after 10 days. So again, it's not commonly recognized that that 10-day to 35-day, 10-day to 42-day period of time is a critically important time. And all the data we have, data from the USA, data from the Commonwealth of Massachusetts, and I'm sad to say, data from Brigham and Women's Hospital indicate that this is a real problem that's continuing. Now I'm taking a screenshot from the package label of Betrixaban. This is the modified intention to treat efficacy analysis that the FDA used. In their composite outcome, there was a 25% reduction of asymptomatic events, symptomatic events, non-fatal PE, and VTE-related death with Betrixaban compared to Enoxaparin. Now, let's look at what the FDA is instructing us about the indications for Betrixaban. And they're very broad indications. So the indications for using Betrixaban, according to the FDA, are much broader than what was done in the clinical trial to test Betrixaban. But I'm going to just read from the indications and usage screenshot. Betrixaban is indicated for prophylaxis of VTE in adult patients hospitalized for an acute medical illness who are at risk for thromboembolic complications due to moderate or restricted mobility and other risk factors for VTE. Full stop. Well, that's millions of patients each year. Now, it turns out that we in vascular medicine, I'm a vascular medicine cardiologist like Dr. Compier, we don't think that VTE is really all that different from a pathophysiological viewpoint than stroke or myocardial infarction. So we had an a priori hypothesis before we started the APEX trial, which was that Betrixaban could prevent stroke or prevent a second stroke in the patients who were hospitalized with stroke, as well as prevent DVT or PE, because we think the pathophysiology is very common. And what did we find? We found Betrixaban had a 56% reduction in new stroke compared to Enoxaparin in the APEX trial. The two groups of patients who benefited the most from stroke reduction were those 45% of patients enrolled in the APEX trial with congestive heart failure, and the 10% of patients who were enrolled with an initial stroke. Okay, I've been talking to a lot of you informally, both today during the breaks and last night at our faculty dinner about cost effectiveness, because Betrixaban costs a little more than Enoxaparin. Even for John Finikos, who directs our pharmacy and who is known to be the best negotiator of lower drug prices of any hospital pharmacy director in the United States. I think Betrixaban costs John about $9 per day, and Enoxaparin costs him $3 or $4 a day. And you know, we live in the real world where we're reporting to vice presidents, and we have to give a lot of rationale if we're going to put more of an investment into a new drug. So what's the rationale for spending more money, aside from alleviating the, I mean, I think in one case you could say you don't need any numbers, because you know, you're preventing PE, you're preventing DVT, you're preventing stroke, you're preventing fatal and irreversible events, but in the world we live in, that's not necessarily enough. You need to show more than that. Well, okay, how about preventing rehospitalization or VTE-related mortality? It's very expensive to rehospitalize a patient within 30 days. Medicare is very unhappy with hospitals and those in hospital leadership at places where there is rehospitalization within 30 days. Everybody knows that the #1 cause for rehospitalization is heart failure within 30 days. Guess what #2 reason is across the United States for rehospitalization within 30 days? It's pulmonary embolism. And in the APEX trial, there was a 47% reduction in rehospitalization within 30 days, rehospitalization that was related to a new pulmonary embolism or DVT, and rehospitalization related to an eventual VTE-related death. And I think when you consider the cost of rehospitalization, and when you add on the penalties, the financial penalties that Medicare imposes upon hospitals with a high rehospitalization rate, Betrixaban becomes very cost-effective. If you just look at VTE-related hospitalization without the VTE-related mortality reduction, there's a 56% reduction in VTE-related rehospitalization. And if you want to look at VTE-related mortality, there is a 42% reduction in VTE-related mortality. And here's the combo of VTE-related rehospitalization and VTE-related death, a 47% reduction with Betrixaban compared to Enoxaparin. Well, where do you get the most bang for your buck with this Betrixaban? It turns out if you've had a prior DVT or pulmonary embolism and you're hospitalized with medical illness and you're randomized to Betrixaban versus Enoxaparin, the Betrixaban group has a 43% reduction in new VTE, and the number needed to treat is only 12 patients. If you take patients with no history of VTE, the number needed to treat is 100 patients. Not shown here is another fact that we submitted a manuscript for yesterday. If you look at ICU patients, intensive care unit patients, about 10% of the patients in the APEX trial had been in intensive care units. Those patients, the number needed to treat is about 10 in order to prevent one pulmonary embolism or DVT. So in summary, Betrixaban compared with Enoxaparin showed a 24% reduction in all VTE, a 46% reduction in symptomatic VTE, a 56% reduction in stroke, no increase in major or fatal bleeding, and a favorable net clinical benefit. And in the sub-studies of the APEX trial, Betrixaban compared to Enoxaparin had a 29% reduction in fatal or irreversible outcomes, a 56% reduction in VTE-related rehospitalization, a 42% reduction in VTE-related death, a 47% reduction in the combo of VTE-related rehospitalization and VTE-related death. It had a lower thrombus burden due to better clean out of the veins, and that helps explain Betrixaban's legacy effect compared with Enoxaparin. Now, our ongoing challenge, and we'll be discussing this more this afternoon, is to convince, first of all, healthcare providers that the VTE problem is not yet solved. Because a lot of people think it was solved with the Enoxaparin and the Metanox trial. It's not yet solved. The last frontier of preventable VTE is this vulnerable period, especially the first month after hospital discharge. And of course, we have to go before our P&T committees, as I did with our partners P&T committee and our Brigham and Women's Hospital P&T committee. And if you get the drug past the P&T committee, the next challenge is implementation and raising awareness of the problem and improving coordination of care. Thanks very much. If we could have the next slide deck, please. We're going to start getting into the implementation issue because implementation of Betrixaban begins in the hospital in the same way that a patient is getting, who's being hospitalized, is getting prophylaxis against acid reflux or constipation. VTE prophylaxis is part of the fundamental order set, and those who are taking care of these hospitalized patients more and more are hospitalists. Hospital medicine is a specialty that's the most rapidly growing specialty in the United States. I can't think of any better speaker than Ebrahim Barkuda, who runs the hospital program, hospital medicine program at Brigham and Women's Hospital and Brigham's Faulkner Hospital. He's going to describe to us an innovative, cutting-edge, and state-of-the-art action plan. And I think, Ebrahim, this is also your first time at this wonderful Dearborn conference.
It is my first time.
So let's give Ebrahim a big welcome.